بسم الله الرحمن الرحيم. Welcome to this new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. Really, I am so pleased and honored today to have the great moderator, Professor Tariq Baz, and one of my dear friends as a speaker, Professor Mohamed Kamal Nassar. And our topic today is about one of the endocrine kidney topics or kidney endocrine interaction is about GLP-1 agonists and the kidney. Before I leave the floor to our great moderator to lead this meeting today, I am to introduce him first. He is my dear professor, Professor Tariq Baz. Professor Tariq Baz is the Emeritus Professor of Nephrology and Medicine at Al-Azhar University. He was the past president of National Kidney Foundation and the founder of World Kidney Day in Egypt, and then the president of Egyptian Society of Nephrology and Transplantation. Followed by, he was the president of Arab Society of Nephrology and Transplantation. And now Professor Tariq is the member at large of Arab Society of Nephrology and Transplantation board, and we are honored to have him in all of our scientific meetings and all of our young generation's thesis discussions. And I don't think that no one discussed thesis for young generations more than our dear Professor Tariq. He is known by his publications in the CKD, and he is the clinical nephrology chapter chair of Egyptian Society of Nephrology and Transplantation. So please, Professor Tariq, take the floor and lead this meeting, and we will come back again to you after the lecture for discussion. Thank you so much.
Thank you very much, Professor Yasser, for your very kind invitation and kind words. I'm really very happy and enthusiastic about this topic in particular, and having a great friend who is a master of this topic. As a matter of fact, Professor Mohamed Nassar from Mansoura is currently running the Nephro-Metabolic Forum. And this just speaks, the title speaks of itself. He's going to talk about how these new drugs that were originally made to treat diabetes are now used to treat the kidney. There's very exciting results lately. I'm sure he will tell us all about these results and more to come. So please, to save time, Mohamed, start sharing your screen, please. Thank you.
Okay, thank you. Thank you very much, my dear Professor. Thank you, Dr. Yasser, for this kind invitation. Actually, this is the third time to be here. It is my honor to participate in the activities of the ASCNT CME activities, and I hope it will be an interesting lecture for you. Today, inshallah, we'll talk about the GLP-1 agonists and kidney. Firstly, we know that the cardiovascular, renal, and metabolic systems are closely interlinked. Each one is affected by the other. There is the cardiorenal metabolic continuum or cardiorenal metabolic link. As we know, diabetes is the leading cause of end-stage renal disease. Patients with diabetes are 10 times more likely to develop end-stage renal disease than those without diabetes. About 40% of adults with type 2 diabetes have a chronic kidney disease, and even the survivals on dialysis are worse in patients with diabetes versus non-diabetic patients. The diabetes is the most common cause. Approximately 40% of patients with type 2 diabetes develop chronic kidney disease, and it is the most common cause worldwide of end-stage kidney disease. Even mortality or the presence of albuminuria and reduced GFR and the presence of both is associated with increasing mortality in type 2 diabetic patients. Okay, so this is the focus of the talk today. We'll start by the gut-kidney axis and the role of GLP-1, the incretin-based therapy, the GLP-1 receptor agonist in the cardiovascular outcome trials, the renal trials, comparison between GLP-1 receptor agonists and other drugs, and finally with the conclusion. Let's start with the gut-kidney axis. The gut hormones affect, as we know, the postprandial insulin secretions, what's called the incretin effect. As we see here, this is the difference. This is the difference between the oral and intravenous glucose. It is associated with increased insulin secretion despite achieving the same glucose or blood glucose or plasma glucose concentration. And of course, this is mediated by the two gut-derived incretin hormones, which are the glucagon-like peptide 1, GLP-1, and glucose-dependent insulinotropic polypeptide, which is GIP. Actually, the GLP-1 is present in many organs, in the brain, in the heart, in the stomach, and it's also present in the kidney. It can be present in the afferent arterioles or juxtaglomerular cells. They noticed that also oral administration of sodium elicits a greater natriuretic response compared to intravenous administration. As we see here, there is increased in the urinary sodium excretion while using the oral sodium load. And as we see here, it is continuous for 24 hours, despite there is no difference in the RAS components, arterial natriuretic peptide, or blood pressure. This highlights the potential role of gut-derived hormones such as GLP-1 that can be associated with or modulate the sodium excretion that can differentiate between the oral and intravenous route. Also, they noticed that GLP infusion induces natriuresis, marked increase in the natriuresis, and the acute infusion of GLP-1 receptor agonist exenatide was associated with increase in the fractional sodium excretion and also urinary pH. So actually, there is a link between the gut and the kidney, and this link is mostly mediated by the GLP or the incretin pathway. Okay, what about incretin-based therapy? These are the effects or the biological actions of incretins, GIP and GLP-1. They are mostly similar. They can affect the pancreas, inducing increase in insulin secretion and decrease glucagon secretion. They affect the GIT, especially GLP-1, by delaying the gastric emptying. They have anti-inflammatory and antioxidant stress effect, and of course, the cardioprotective effect, as we'll discuss later on. Actually, the physiological targets of GLP are diverse. It can be present or it can affect the gut, the stomach, producing many effects: pancreas, brain, white adipose tissue, brown adipose tissue, immune system, liver, skeletal muscles, heart and vessels, kidney. So this system can be presented in all organs in the body, and its function by multiple pathways. It can be either DPP-4 inhibitors, we will not discuss today, or the GLP-1 receptor agonist. The GLP-1 receptor agonist can be either human GLP-1 receptor agonist or exenatine-based agonist, and the newcomer, which is the combined B and GIP receptor agonist. These are the available drugs, the incretinomimetics, which are short-acting, high immunogenic power, reduce postprandial glycemia, eliminated by the kidney. They include exenatide, and these are the trade names, lexazenatide and exenatide long-acting. The newer GLP analogs or human GLP analogs, which are long-acting with low immunogenic power, reduce hemoglobin A1C and the fasting blood sugar, and eliminated by proteolytic degradation, including dulaglutide, semaglutide, liraglutide, and the oral semaglutide, which is Rybelsus. This is the generic and the commercial name regarding the frequency of administration, initial doses, and recommended doses. And this is the EMA recommendations for renal modifications. It can be used up to the semaglutide up to GFR 15, but in the FDA, it can be used up to end-stage renal disease. So this is the different consideration or the different renal modification of the GLP-1 receptor agonist. And I want to stress that they are, from my point of view, or my point of view, they are heterogeneous group. They are not all similar. They are not all similar drugs, and we will discuss this later on. Okay. Let's come to the next point, which are the cardiovascular outcome drugs. As we know, starting from 2008, any new antidiabetic drugs before introduction, it should undergo a cardiovascular outcome trial to assess the safety of the drug. And this is the rule from 2008. This meta-analysis included 8 trials, including more than 60,000 patients, type 2 diabetic patients, using the GLP-1 receptor agonist to assess the cardiovascular mortality and the kidney outcomes. These are the studies using different drugs, Alexa, lexazinotide, liraglutide, and so on. And this is the baseline GFR. Actually, again, this is a cardiovascular outcome. So they include patients with mildly or even normal GFR, and the use of GLP-1 receptor agonist was associated with favorable outcome regarding the 3-point MACE, major adverse cardiovascular events, regarding the cardiovascular death, fatal or non-fatal myocardial infarction, and fatal stroke. The all-cause mortality was better with GLP-1 receptor agonist. Hospital admission slightly reduced. Composite kidney outcomes, including macroalbuminuria, were reduced by about 21%, but worsening of kidney function was not significantly improved. So they found in the cardiovascular outcome trials that the use of this drug is associated with improved proteinuria, but there is no significant improvement in the worsening of the safe drug. Another trial renal protection in type 2 diabetic patients, including 7 studies. These are the studies. They found again improvement in the composite again, this is the meta-analysis regarding the use in GLP-1 receptor agonist in type 2 diabetes to assess the cardiovascular mortality and the kidney outcomes in patients with type 2 diabetes. This meta-analysis included 8 trials, including more than 60,000 patients. These are the included studies, including different drugs, lexazinotide, liraglutide, semaglutide, and other drugs. And this is the baseline kidney characteristics. This is a cardiovascular outcome trial. So they are concerned with the assessment of the safety of the drugs. As we said, they started in 2008 to assess the cardiovascular safety with any new anti-diabetic drug. So these patients are with normal or even mild reduced GFR and low grades of albuminuria. They found that the use of GLP-1 receptor agonist was associated with reduced the major adverse cardiovascular events, 3-point MACE, and cardiovascular death, fatal or non-fatal myocardial infarction, and fatal or non-fatal stroke. The all-cause mortality, hospital admission for heart failure, and the kidney outcomes. But we should differentiate between the kidney outcomes, including macroalbuminuria and worsening of kidney function. The macroalbuminuria was reduced, but when they focused on the worsening of kidney function, there was no difference between or significant difference between the GLP-1 receptor agonist and the other drugs or placebo. And the drug was totally safe, no mark or no increase in the adverse events. Another study to assess the renal protection in type 2 diabetes was again a meta-analysis that included 7 trials. And that are the drugs included and the studies included. Again, when they discussed the all composite renal outcome, including the macroalbuminuria, reduction of the albuminuria, or worsening of kidney function, there was a significant improvement in the with the use of GLP-1 receptor agonist. New macroalbuminuria was reduced by 25%. But when they focused or they studied the kidney function change, GFR decrease, doubling of serum creatinine or end-stage renal disease, there was no significant change with the GLP-1 receptor agonist. So we should differentiate between the antiproteinuric effect and the kidney function improvement with the use of this drug. And as we see in this another meta-analysis, there is a difference in the results between the drugs. The lexinatide is different from the liraglutide and semaglutide and dulaglutide. I think this group is not is a heterogeneous group. It is not a homogeneous group. There are differences in the results between the different drugs, and the newcomer, which is the combined GLP-1 and the GIP, tirzepatide, was associated with marvelous improvement in the renal endpoints, reduction by more than 40%, and all the drugs were associated with a decreased or a significant effect on the macroalbuminuria. So again, in this group, we should differentiate between the anti-albuminic effect and the kidney function effect. Okay, let's pass to the next points, which is the renal trials, which is the GLP-1 receptor agonist. This trial assessed the effect of GLP-1 receptor agonist liraglutide in patients with severely impaired kidney function, diabetes, and CKD. They divided the patient in two groups, the GFR more than 60 and less than 30. They found that there was a mild increase in the low GFR in the systolic blood pressure, no effect in the patients with normal kidney function or GFR more than 60. And there was a difference in the natriuretic effect, as we see the difference between the patient with low GFR and normal GFR. So even in patient with low GFR, the drug has a natriuretic effect. And this is the different groups. The GFR less than 30, it was associated with increase in the atrial natriuretic peptide and a decrease in both aldosterone and renin system. So it has a favorable effect on the renin angiotensin aldosterone system and increase in the natriuretic peptides. So this drug has a renal hemodynamic effect. It decreases GFR through increasing sodium afflux to the macula densa, restoring tubuloglomerular feedback and vasoconstriction of the afferent arteriole. And it has a marked anti-albuminic effect by decreasing the plasma renal activity, increasing natriuresis, and decreasing the renal oxidative stress. Okay. Let's move to the last trial. They found a renal benefit.
اقفل الكاميرا يا دكتور محمد معلش.
CKD trial or a kidney specific trial. So
دكتور
Yes.
محمد لو سمحت اقفل الكاميرا عشان الصوت يبقى اوضح.
اقفل الكاميرا. حاضر حاضر.
هيبقى الصوت هيبقى اوضح لانه بيقطع برضه.
ثانية واحدة.
اتفضل.
تمام. This is the most recent trial, which is flu trial that was published only a couple of months ago in the New England Journal of Medicine. It was a specific kidney trial. They included more than 3,500 patients with type 2 diabetes and hemoglobin A1C less than 10%. They were using the standard of care treatment, RAS blockade, and the included patients either have a normal or GFR between 50 and 75 with albumin creatinine ratio from 300 to 5,000, or GFR between 25 and 50 and albumin creatinine ratio between 100 and 5,000. These are the included patients. You were divided into two equal groups. The first group received gradual increasing doses or escalating doses of subcutaneous semaglutide every week, in addition to the standard of care treatment, to reach the standard dose, which is 1 milligram, and the other group received placebo in addition to the standard of care treatment for type 2 diabetes and CKD. These are the primary endpoints. So again, a specific kidney trial. So the primary endpoint was the time to the first occurrence of a composite endpoint consisting of a persistent more than 50% reduction in GFR, onset of persistent GFR less than 15, initiation of renal replacement therapy, renal death, or cardiovascular death. And the results were marvelous. They found that the first major kidney disease event was reduced by 24%. The total GFR was slope was better with the semaglutide in comparison to the previous or most of the previous studies that they didn't find an effect on or the favorable effect on the kidney function. And the difference in 1.16 milli per minute per year for the semaglutide. The first major cardiovascular event was reduced by 18, was reduced by 20%, and this from cardiovascular cause was reduced by 29%. So it was associated with very favorable results. Specific kidney trial, again, it is a specific kidney trial with no increase in the serious adverse events and the mild increase. انا بعتذر والله عن النت الفظيع ده. دكتور ياسر،
اتفضل دكتور محمد، اتفضل احنا معاك.
احنا وصلنا
اتفضل. انا ما
ابدا بالنقطه اللي انا واقف فيها.
كمل زي ما كنت، زي ما كنت احنا ما وقفناش.
خلصنا الفلو ترايل تمام.
آه.
اوكي. Okay. This drug appears to have a very favorable results on the kidney or renoprotective effects, either direct effects through the proximal tubular natriuresis stimulation, modulation of cyclic AMP protein kinase A signaling, inhibition of renin-angiotensin system, decreased renal hypoxia, decreased glomerular atherosclerosis, renal insulin dependent vasodilation, and many effects in addition to the indirect effects, including improved glycemic control, blood pressure control, weight loss, increased insulin sensitivity, and many favorable results. And also the decrease in the stress, in the glomerular hypertension, and in the atherosclerotic potential. Okay, so again, it appears that this drug will be one of the standard of care treatments in the patients with diabetic kidney disease, I think, after this favorable or very favorable results of the FLOW trial. Okay, so what about the comparison of this class with other drugs? Let's pass to some studies like this meta-analysis comparing between sodium glucose transporter 2 inhibitor versus GLP-1 receptor agonist. This meta-analysis included 13 studies with more than 30,000 patients. They found that there was no difference between the sodium glucose transporter 2 inhibitor and GLP-1 receptor agonist regarding the major adverse cardiovascular events in kidney patients. The renal outcomes were better, slightly better, with the use of sodium glucose transporter 2 inhibitors. Another study comparing the GLP-1 receptor agonists and long-acting insulin in the patients with type 2 diabetes requiring intensive glycemic control, marked change or marked improvement in renal outcomes with the use of GLP-1 receptor agonist versus the long-acting insulin in the renal insufficiency, in the dialysis-dependent end-stage renal disease, in the renal death, marked improvement or marked benefit with the use of GLP-1 receptor agonist. Another meta-analysis comparing the kidney outcomes between the sodium glucose transporter 2 inhibitors, GLP-1 receptor agonist, DPP-4 inhibitors, and sulfonylurea. The best results for the GFR decline or end-stage kidney disease were for the sodium glucose transporter 2 inhibitor followed by the GLP-1 receptor agonist. Then the DPP-4 inhibitors, and the worst outcome was the use of sulfonylurea. So again, the use of nephro or organ protective drugs should be emphasized in these patients. The all-cause mortality again was the same order for the 4 drugs, and this is the inter-individual comparison. GLP, the kidney outcome, of course, GLP versus sulfonylurea, marked difference. GLP versus DPP-4 inhibitors, also the difference. No difference versus the sodium glucose transporter 2 inhibitors. So it is important not just to control the diabetic state, but it is important to include in your treatment the organ protective drugs. Another trial comparing between sodium glucose transporter 2 inhibitor and GLP-1 receptor agonist in type 2 diabetes with and without albuminuria to assess the cardiovascular and renal outcomes. Regarding the MACE, no difference between the sodium glucose transporter and GLP-1 receptor agonist, either without or with albuminuria. Regarding the renal outcomes, it was better for the sodium glucose transporter 2 inhibitors. The last trial to assess the difference between the drugs that included the newcomer finerenone. This study or meta-analysis compared between finerenone, sodium glucose transporter 2 inhibitors, and GLP-1 receptor agonists. Regarding the MACE, no difference between the three drugs. Regarding the renal outcome, sodium glucose transporter 2 inhibitor was better than both GLP-1 receptor agonist and finerenone, with no difference between finerenone and GLP-1 receptor agonist. Hospitalization for heart failure, better for sodium glucose transporter 2 inhibitors. All-cause death, no difference between the three drugs. Cardiovascular death, no difference between the three drugs. So it is important to focus on the availability and focus in the profile and the character of each drug, and to include, again, more than organ protective drugs. Finally, to the conclusion, this class appears to have a potential mechanisms for the kidney and the cardiovascular protection. In the patient with type 2 diabetes, they improve the weight loss, improve the glycemic control, blood pressure lowering, anti-atherosclerotic effect, natriuretic and diuretic effect, and the anti-inflammatory effect. In addition to the anti-apoptotic and the oxidative stress. So this drug or this class has a myriad of mechanisms to protect the kidney and heart. And the guidelines puts this drug in the second category after sodium glucose transporter 2 inhibitor. It is the preferred choice as additional drug therapy for improving glycemic control if not improved by sodium glucose transporter 2 inhibitor, and it is an alternative choice if the sodium glucose 2 transporter 2 inhibitors are contraindicated or not available. And I think it will achieve a better position in the guidelines later on. These are the frequency and the recommended doses of the available drugs of this class. This is the US prescribing information and the EMA prescribing information, and the difference in the liraglutide that can be used and liraglutide up to end-stage renal disease with caution, but in the EMA, no drug or the drug is contraindicated in the GFR below 15. And finally, these are the cornerstone treatments for diabetic kidney disease. First, of course, the risk factor management, including plasma glucose control, blood pressure, weight control, smoking, lipid, physical activity, and protein restriction. The RAS blockers, of course, the sodium glucose transporter 2 inhibitors, the MRAs, finerenone, and I think in the recent future, it will be also the GLP-1 receptor agonist after release of the results of the FLOW trial. Thank you, and sorry for inconvenience to the internet problems. Thank you so very much.
Thank you, Professor Mohamed. Before I leave the floor to Professor Tariq to comment on this great lecture, I would like to thank our coordinator today, Dr. Mu'tasim Al-Sayed, lecturer of nephrology in Mansoura Nephrology and Dialysis Transplantation Center, and for all of his work in CME chapter activities. Please, Professor Tariq.
Thank you, Professor Yasser. It was a really good talk, Professor Mohamed. You touched all the recent trials, particularly the recent FLOW trial. I would have liked to hear something about the SUSTAIN trial, particularly SUSTAIN 6. Anyway, you covered the subject totally. And one of the good points you highlighted is the fact that not all incretin-mimetics are alike. You clearly showed that the best effects were with semaglutide and the first twin incretin, which is the tirzepatide. And another good point related to the semaglutide, that it can be used down to a very low GFR rather than the other forms of incretins. You did mention the mechanism of how these drugs are effective, and maybe just recently I read an article just a few days ago about how these drugs are working. They are improving the metabolic profile within the kidney through improving the mitochondrial function and shifting the metabolism to lipolysis rather than glycolysis. And this could really help with a lot of what we've been hearing lately about the lipid influx to the kidney. I guess something else that I like to add is related to the metabolic profile of these drugs. We all understand that they are marvelous in the essence of weight reduction. And I could speculate that a lot of effects could be simply related to weight reduction, whether blood pressure control, which would reflect on the lower incidences of MACE, and in sustained trial, when they looked at the 3-point MACEs, definitely it was much better. And so simply reducing the body weight could be of great value. A final point is always there. Some patients really cannot tolerate these drugs. Although it is advocated that we have to work up with the dose, yet there are some patients that could not really tolerate the gastrointestinal symptoms related to these drugs, but in the majority, they are mild as long as you are prescribing these drugs as has been mentioned in the guidelines of prescription, gradually increasing the dose of these drugs. Now, Professor Yasser, maybe there are some comments or questions from the floor.
Professor Hisham Sayyid, please.
Thank you, Mohamed. I enjoyed, as usual, you touch all the points in the same time. I have no any questions, but I am talking to myself with a very scanty voice. How we can approve all this mechanistic action for all drugs? I'm not meaning by GLP-1. I mean it, how they approve that it's anti-apoptotic, anti-fibrotic, anti. What is the basis of their conclusions? For we understand that some of the sodium glucose transporter, there is a mechanistic physiological function, but even SGLT2 still has a hypothetical speculation of mechanism of action as exactly as GLP-1. The most one who are really have the same action is the MRA, finerenone. So from your readings, did you find any talk or literature in depth explain these tons of advantage and the function? We understand the protection way, follow up the patient, proteinuria, CKD. Even in CKD more than 5 years, you cannot speculate. It is on the plot, just speculating the curve. So if you are read some about that, it's approved or not proved, this mechanistic function.
I read some articles include, as Professor Tariq said, as affecting the mitochondrial function. I think the most important interaction of the drugs is through the mitochondrial function, through the anti-inflammatory effect, through the anti-apoptotic effect, but mostly they have multiple cellular effects or multiple cellular signals. And as I said, this class or this pathway has multiple receptors in many different organs, including the kidney, including the heart, the brain, and this is appears to be the responsible for the myriad of effects that can be associated.
Works fine. It works fine. GLP-1, SGLT2, finerenone, it works fine. But it's still more speculation and a silent Cold War between drugs speculating a lot of function without a proof. That's my belief, but we are prescribing because of the clinical value
effects.
and the results.
Okay.
The evidence-based era, Professor Hisham, I think.
Yes, a lot. All
Don't
the
look-
drugs
don't
are
look for the
antifibrotic,
function. Yes.
all anti-apoptotic. Did you examine the apoptosis? For antifibrotic, did you
I
examine?
think it is examined preclinical, I think, and animal studies, but I didn't focus actually on this evidence.
Okay, thank you very much, Mohamed. As usual,
Thank you, Dr.
we always enjoy your talk.
تسلم يا فندم، متشكرين.
I have a comment and a question, please, Professor Tariq. First, my comment is I totally agree with you that the tolerability of these drugs is the major barrier that we ignore mostly in their use. And many patients cannot continue to use these drugs to the desired doses, as Professor Mohamed mentioned, because of tolerability and marked GIT upsets they feel. And my comment has a question to Professor Mohamed. You said that the action is different between different members of the group. It is not a class effect, it is a drug effect. This is not the state, for example, with SGLT2 inhibitors. Although they act all on the same mechanism of action, as Professor Hisham discussed a few seconds ago. How can you explain the difference, or can you give us an example for cause of this difference between two drugs, for example, or more, why they are different regarding their action or in spite of acting in the same mechanism of action?
Actually, this is my impression regarding from my readings, and as I said, there are two different categories of this group: the old group or incretin-mimetics and the human or the newer comers. Actually, the results were associated with, or the studies was associated with different results. With the best results were for the semaglutide and liraglutide. This is my impression. I think they may be like beta blockers. Beta blockers are not homogeneous. Is not an homogeneous also group. There is difference between the different generations regarding the selectivity and the vasodilator potential. But actually, till now.
You said a difference in selectivity, it's difference in the receptor function, but here it is not the same.
Different in the profiles, difference in the elimination. We have two generations, the old generation and the new generation. Actually, the most of the studies were done on the old generations. And as we see, there is heterogeneous inside the first plot. There is a difference between the effect of different drugs. Actually, this is not an this is my impression from my reading, and I think this class will have more evidence in the next future.
So you cannot give us other, Dr. Tariq.
I'm sorry. If you allow me just to add, the point of difference is not what the drug is doing, rather than the efficacy from retarding the kidney progression or the CKD progression point of view. I mean, all of these drugs would decrease the blood sugar, right?
Yes, of course.
And as you showed in the graphs, the different drugs, the analogs and the mimetics, they are all affecting or retarding the progression of chronic kidney disease, yet there are differences related to the new form, which is the semaglutide, and definitely the tirzepatide, which surpasses all the previous analogs. Maybe this is just because it is the first of its kind, the tirzepatide. Maybe there will be a new one. And by the way, there's going to be a 3-in-1, a combo drug that will include a third drug together with the twin incretin, which we have to wait to see what about this drug, what it is going to do.
Incretin
So
and two incretins and insulin?
Not insulin, 2 incretins and something else. Maybe it's an SGLT2 inhibitor, all will be together in one tablet.
Oral form.
It's not tested yet in trials related to prevention of progression of CKD, but we just have to wait until it is tested to see. These drugs are really marvelous in something which I think is of a great value in weight reduction. Obesity is a major health risk. And as I said in my earlier comment, that I'm just speculating that a lot of the benefits would be simply related to reducing the weight, particularly for dyslipidemia and for blood pressure control, even modest blood pressure control. Mind you, this drug, the semaglutide, does reduce the blood pressure by a very significant levels, up to 10 millimeters mercury. So this in itself could have a very beneficial effect, particularly on the occurrence of MACE. And naturally, if you have a controlled blood pressure, this would also have a very positive effect on the progression of chronic kidney disease. They did not show really significant decrements of albuminuria in the SUSTAIN 6 trial, although the GFR, yes, the microalbuminuria did not decrease. Yet I don't like always to coin diabetic kidney disease in relation to microalbuminuria, because we understand that diabetic kidney disease encompasses other pathological entities that do not have proteinuria at all. So I'm not going to use always proteinuria as a surrogate marker. But in a patient who is already has microalbuminuria, yes, you can categorize the patients in relation to the presence of proteins in the urine. But we have to understand that a good percentage of our type 2 diabetic patients who are progressing to CKD do not have proteinuria at all. And this is something I always like to mention in order to have it in front of us, and not to overlook just a patient because he doesn't have microalbuminuria. Maybe he has diabetic kidney disease, which would progress again to end-stage renal disease. Right.
Thank you so much. So
Thank you.
if we recommend a drug for the kidney, how can we arrange, Professor Mohamed and Professor Tariq, these drugs? Is it semaglutide first and liraglutide coming later on for regarding the benefits?
I think if tirzepatide is available, will be the best. Those associated with very marvelous results in the kidney function and the proteinuria.
So it is now semaglutide first for the kidney if we are looking for organ products.
Yes, because the semaglutide and maybe all of them are not excreted via the kidneys. So that's why they are marvelous in chronic kidney disease. You don't have to have the best of renal functions in order to secrete these drugs. They are metabolized by lysosomes and not excreted via the urine at all. That's why you can use them with the GFR that is considerably low.
Okay, thank you so much. We have no more questions and no more comments, and we can close this very interesting meeting. Professor Tariq and Professor Mohamed. Please, Professor Tariq.
Thank you very much, Professor Mohamed. It's a great talk as usual and very informative, and hoping to meet you in future meetings, inshallah.
inshallah. نشوف حضرتك على خير. شكرا جزيلا.
Thank you, Professor Mohamed, for this very interesting lecture. Thank you, Professor Tariq El-Baz, for being with us in this very interesting night. And thank you for all professors who joined us and for all audiences. And again, for Dr. Mu'tasim Al-Sayed for all of his help in this CME chapter activities. Thank you, and excuse me to close this meeting. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
شكرا.
وعليكم السلام.
شكرا. السلام دكتور طارق.